honor to introduce our speaker today, Tamara Duker Freuman. Tamara is a nationally known expert in digestive health and medical nutrition therapy for gastrointestinal diseases. In addition to her clinical work and regular speaking engagements at national GI conferences, she's a high-profile nutrition writer. Her first book, The Bloated Belly Whisperer, was published in 2018, and her latest book, Regular, The Ultimate Guide to Taming Unruly Bowels and Achieving Inner Peace, was published in 2023. And without further delay, I'll turn it over to you, Tamara.
Thanks, Jocelyn, and thank all of you for being here today. It's a topic that I talk about a lot, near and dear to my heart, but I am always thinking about new ways to talk about it and teach about it and for us to think about it. So I'm workshopping some new models today, and you guys, I'm sure, will send some feedback and let me know if it landed well. And I have a lot of material, so I talk fast anyway, and I'm going to talk extra fast so that we can get through it all because it's very hard to edit myself on this topic. So we're going to talk about leading medical causes of abdominal bloating, and we're going to talk about the pathophysiology of them. We're going to give you some tools and ways to try to assess the likely causes of a patient who comes to you complaining of bloating, the kinds of questions you can ask and the clues that you can be looking for. And then just to give you an idea of the array of different dietary approaches that you as a dietitian can use to help patients manage their abdominal bloating on the basis of what you think is causing it or what you have, what's been confirmed and diagnosed. So without further ado, I want to talk about bloating and distension because, they are two different things. And often patients use the term bloating to refer to distension or distension and bloating. And I think it's important if you are trying to assess a patient, but when a patient comes in and says, I'm bloated, I'm so bloated all the time, to stop and make sure that we're all talking about the same phenomenon. So bloating is a subjective feeling of pressure or fullness from within. You feel overfull, you feel uncomfortable. It's not overtly painful, but it is an uncomfortable sensation. It may be accompanied by distension, but it may not be. All right, distension is just an objective increase in your waist circumference. You can be distended, but not feel uncomfortably full and bloated. You might kind of look pregnant and your belly might be sticking out, but you're hungry, you're not overfull, like you have a good appetite, you're not uncomfortable. And you can be bloated and feel overfull, but not actually look distended. Or you can do both. I will say most patients who complain of bloating are complaining of both bloating and distension, but I think it's kind of helpful to ask and clarify that we're all talking about the same thing, because there are some conditions that typically only present with distension without discomfort. And there's some conditions that present really just with the discomfort and don't look distended. And if you can separate the two, it might really help you home in quickly on what's causing your patient's problem. So bear that in mind. So let's talk about the bloating side of it first. Bloating, that subjective feeling of fullness. What causes that? There's two main things that cause bloating, which may or may not be accompanied by distension, right? So this is just the pressure feeling. The first is that there's more pressure or more stuff inside your bowels. Okay, where does that come from? Maybe it comes from the fact that you have gastroparesis, delayed gastric emptying. So there's literally a meal sits in your stomach for hours and hours after you've eaten it, and there's just more stuff in your stomach. Sometimes you might feel fuller after eating even a normal amount because there's impaired gastric accommodation. Gastric accommodation is stomach stretch, right? Your stomach is supposed to stretch after you fill it with food or liquids. And sometimes if there is impaired stretchiness, you will feel uncomfortably full really quickly after eating or drinking something. There can also be sort of abnormal accumulation of gas or pooling of gas, which can have to do something with the motility of the bowel and how gas is kind of, cleared or propelled throughout the length of your intestines. So for example, you and I might have the same exact amount of gas in our intestines, but if you have IBS or some sort of dysmotility, maybe all of your gas starts to accumulate in one or two areas. You can kind of see that and demonstrate it in the schematic on the right. you know, how you have these like fewer larger pools of gas, whereas a person on the left has small little pockets of gas spread really evenly throughout the GI tract. That's going to feel really different to somebody. And so it's not necessarily that somebody with IBS who complains of a lot of bloating might have more gas. In fact, we've seen studies that suggest that they don't have more gas. They just have differences in how they propel it and expel it. Sometimes people are unable to expel gas. Some people cannot belch. We're going to talk about that condition later in this talk. It's called RCPD. And some people have a hard time farting because they have pelvic floor dysfunction. If they have hypertensive anal sphincter that doesn't fully relax, it can just be hard for them to release gas. They have to contort themselves, go into yoga positions just to fart. You could imagine if you don't easily clear gas from up above or down below, how it could start to accumulate and feel really uncomfortable. And then there's an issue around visceral hypersensitivity. And this is really what is affecting your patients with disorders of the gut-brain interaction, DGBIs, such as IBS, which is they have normal amounts of stool, normal amounts of gas, but they just feel every single, nugget of stool, every single bubble of gas. Their nerves are so hypersensitive. They have a lower threshold for discomfort relative to people who don't have IBS. And so they feel subjectively more full, more bloated, more uncomfortable when there is stuff in the GI tract, whether it's gas, whether it's stool, whether it's just a larger size meal. They just feel everything at a much lower threshold. And that's why they feel bloated more often than your patients who don't. And so you could imagine that the types of interventions that would help a patient like this would either be neuromodulator medications that kind of influence how the nerves perceive stimuli, or reducing the stuff in the GI tract that, that is kind of being picked up on by those nerves. So like helping reduce the gas burden, helping reduce the stool burden, making sure the meals aren't too big at once. Like those are the things that just will kind of fly under the radar of those really sensitive visceral nerves. There are also many behavioral therapies for visceral hypersensitivity. And there are sort of ways to kind of address the brain aspect of the brain-gut interaction. Everything from diaphragmatic breathing. Diaphragmatic breathing activates the vagus nerve. Your vagus nerve is the central component of the parasympathetic nervous system, the calming you down nervous system, or what we like to call the nervous system that's responsible for resting and digesting. Right? That's the opposite of your sympathetic nervous system, which is sort of like the I'm a prey being chased by a predator. That's the adrenaline. That's the blood flowing, to my limbs so I can run fast. The vagus nerves gets the blood flowing inward, to the GI tract and really helping kind of reduce the stress response. Cognitive behavioral therapy is another way that you can kind of enlist the brain's help to interpret stimuli from the gut in a less catastrophizing way. Gut-directed hypnotherapy is sort of enlisting these subconscious GI processes and bringing them under more conscious control. Everything stems from your brain. Your brain controls motility. Your brain controls pain. Your brain controls your heart rate even. And so by enlisting the brain to be a little bit less passive and a little bit more consciously proactive with some of these processes, you can actually enlist the help of the brain to regulate processes and also to kind of tamp down that pain thermostat. And not available yet, but there has been at least one pilot study using virtual reality to help recalibrate the brain's perceptions and sensations of pain and discomfort. And it's been, I think this particular pilot study was for patients who had functional dyspepsia. And so a lot of new and emerging ways to use the behavioral side to address visceral hypersensitivity, which would be done mostly by a GI psychologist or a hypnotherapist who does sort of GI-based hypnotherapy. Okay, that was bloating. Now let's talk about distension. Why does the belly physically look distended and pregnant looking? What's going on there in your body when that happens? So the first is that you have abnormal neuromuscular responses to stuff in the GI tract or to eating or to putting things in the body. Okay, there's a condition. It is called abdominal phrenic dyssynergia, APD. There's more and more papers and literature about this now. It's becoming more and more understood. I put a direct quote defining what is happening with the nerves and the muscles in this, and the citation is that little one on the bottom of the screen. It's just a recent article that was published in I think Medscape or Med something, MD Edge. And I just loved how they explained it. I found it so clear, so I lifted it and put it in quotes. But what's happening here is that when you eat, the normal response to the stomach filling up with food or water or whatever is that your diaphragm, which rests right on the top of the abdominal cavity, separates your lungs from your abdominal cavity. The diaphragm is supposed to lift up, okay, and relax to allow more space in the abdominal cavity for the stomach to stretch, right? The diaphragm lifts, makes more space. And the abdominal walls are supposed to kind of hold their form a little bit. And what's happening in this abnormal response is that paradoxically, the diaphragm starts to contract or push down and descend into the abdominal cavity, making the abdominal cavity smaller, just at the time when the stomach is filling up with food and needs more space. So then how does the abdominal wall have to respond to that? Now all of a sudden, we've lost that real estate up top. The diaphragm's pushing down, so the abdominal wall just completely relaxes and gives out like you've just eaten Thanksgiving dinner. And you get this very distended looking appearance. This is a picture of a patient of mine. She's 5 feet tall. She's about 110 pounds. This particular patient had a history of longstanding binge eating disorder. And, I think what happened to her over time is that the abdomen got so acclimated to sort of processing very large volumes of food during binge eating that it just started just like completely like its new automatic response. It kind of got trained to completely relax. So this is, what somebody with abdominal phrenic dyssynergia might look like after eating like a granola bar or like, a half a cup of water. The abdominal wall just completely gives out and it looks very pregnant looking. There are ways to address this type of distension, biofeedback, sort of retraining the neuromuscular response back into a more physiologic normal response. There are neuromodulators, medications that affect the nerves, muscle relaxants, which you think like, oh, like why should that work? But it actually relaxes the diaphragm. So the diaphragm isn't contracting down. Bowel regimens, making sure that you're not also full of stool, simethicone to break up gas bubbles, because obviously anything else that's taking up space in this abdomen is just going to exacerbate the distended appearance. And then working with patients on sort of like little mini meals, grazing, not eating as much at once can reduce the severity of the distension in patients who have this issue until it can be better treated medically. I think it's also worth mentioning when you work in the space of bloating and distension, sometimes you have to probe a little bit around whether the patient truly is distended and bloated or whether there's some body dysmorphia going on. I think, there are a significant number of the patients that I see who have restrictive eating disorders will often complain of bloating and distension as a reflection of body dysmorphia. And so we have this split screen. You see kind of the two pictures on top of sort of like these, white women in small bodies who are often the phenotype of the patient that I will see who has body dysmorphia in this kind of space, where you can see that there's a small body and there is a belly protrusion that is different from the morning to the nighttime. That does look kind of pregnant. That does look very distended relative to their baseline frame, more so than you would expect from eating a meal, right? Like nobody is completely flat after eating a meal, but this does look sort of like not commensurate with what it would normally look like to eat a meal. But then kind of compare that to the two women on the bottom, and these are just things that I picked up off of Instagram, so I'm not trying to target these particular women. But I honestly cannot objectively tell a difference between the before and the after in this picture. And certainly if there is a difference, it would, I think, be considered well within the range of like a normal amount of stomach stretch after eating something, right? You did put some volume into the abdominal cavity. And so I think that the two women on the bottom, what you're really seeing here is more of an expression of body dysmorphia versus, something that looks more like a true abdominal phrenic dyssynergia in those top two pictures. So that's just something to be aware of, that this does exist and it exists pretty extensively, I think, in the world. Okay. So there's bloating, there's distension, and there's conditions that cause both bloating and distension. How do these map to medical diagnoses or medical conditions? So bloating alone without necessarily having a visible distension is something you see a lot in functional dyspepsia, which we'll talk about in further slides. Kind of like IBS of the stomach is how I like to think about functional dyspepsia. With IBS in general, right? Like someone with IBS might feel bloated all the time. They might not necessarily look distended. People with acid indigestion will often feel like after they've, eaten like tomato sauce or like, had alcohol or whatever, and they start to get like acid reflux or dyspepsia, will often say that they feel really bloated. They might be burping a lot, but their belly might not necessarily be very distended. And just like overeating in general, like I think we've all probably experienced this when you just like accidentally eat too much or on purpose eat too much and you just feel really uncomfortably full. And you may or may not actually look really distended and have to like unbutton your pants. There are some conditions that might just be bloating, subjective feeling, or might also have distension. And that's kind of those 4 bullet points sort of on the green to the right. Aerophagia, swallowing air. When people swallow a lot of air, they feel very full. Sometimes they're even short of breath, but they may or may not be distended. Sometimes they are, sometimes they're not. RCPD, which we're going to talk about on a further slide. These are just people who can't burp. And again, similar to someone with aerophagia, they're full of air, and it can feel really full. They may or may not be distended. People with gastroparesis, same thing. People with carbohydrate malabsorption, lactose intolerance, sucrose intolerance, fructose intolerance, they may or may not also be distended, but they certainly feel very full because they have a very high gas burden. Okay. Moving into the space that is purely distension, that's the abdominophrenic dyssynergia, which we just talked about. We saw those pictures. That's just the muscle being really, really relaxed and the abdominal, like everything kind of hanging out. Most of those patients don't also feel uncomfortably overfull. I can't fit any food in my body. I never have an appetite. You're generally not hearing that complaint from them. It's not painful. It's just embarrassing. They say, people give me the seat on the subway. They think I'm pregnant. But it's usually not, they're not overfull. Their appetite's fine. Like they're not in any pain. They just don't like how they look, or their pants literally don't fit them. And they have to have like different pants for morning and nighttime. And then you kind of have, there are some medical conditions that cause distension without a feeling of digestive bloating. And these are often things that are non-digestive conditions. So endometriosis, I think, is a huge one that probably doesn't get talked about enough in the bloating space. And if I were doing an update of my Bloated Belly Whisperer book, I would probably add a section on endometriosis because I think, I overlooked it when I wrote the book the first time. Ovarian cancer, unfortunately, and that would be you're bloated or distended, I should say, not bloated, because of a tumor. And it's not in your GI tract. And so, but you will be very distended. And ascites, right, having extra fluid in the abdominal cavity due to liver disease would also be something that might cause a very pregnant looking distension, but not necessarily feelings of bloating in your digestive tract. And I would say probably the number 1, 2, 3, and 4 reason that somebody is feeling both bloated and looking distended is that they are full of stool. Constipation is probably, I used to say 40% of what I see, but it's probably more like 60% of what I see. Just people who are completely full of stool. And we'll talk about that later in more detail. And also SIBO, small intestinal bacterial overgrowth. People are often bloated and distended, generally because of a gas burden. When they have SIBO, there's just a lot of gas in the bowels that can create both discomfort and distension. But important to note that some of these conditions are not going to be fixed by a dietitian, right? Like swallowing air or not being able to burp, like there's no diet for that. So just being aware, or like endometriosis, like probably not a diet for that. I mean, maybe. So not every bloating case is going to be fixable by you as the dietitian. I put this little algorithm here just for your reference. We're not going to talk about it really, but this was a paper that was just published in 2023. It's for physicians. It's a medical diagnostic algorithm for understanding bloating and distension. But I thought it was great for us as dietitians to kind of have in our back pocket because there's some good questions, in the orange that you can kind of ask, like just a couple of questions that can kind of lead you down hypotheses that help you kind of really start to probe around whether someone's bloating is because they're constipated or because they're maldigesting some sort of carbohydrate, or, because maybe they have slow gastric emptying or dysmotility or SIBO, and, just some basic questions and kind of like the top medical conditions that are on a doctor's differential diagnosis, I think is kind of helpful. So this is an ACG 2023 expert review that you can look up on PubMed. It's free. Okay, so as dietitians, how can we start to probe and get some clues as to why our patients might be bloated or distended? The first thing I'd like to really ask is whether they have gas. Are you gassy? And if so, is it burping gas or farting gas? If it's burping gas, you're generally thinking about an upper GI etiology, right? You're thinking about swallowing air, you're thinking about, acid reflux, maybe thinking about gastroparesis because things are just so slow and, things coming up. Sometimes SIBO is more belchy, but generally speaking, SIBO is more farty. And if people feel like, sometimes they'll say like, I feel like a balloon, I feel like I'm full of air. I would ask them, do you burp? And if they say no, I might say, can you burp? Do you know how to burp? Are you able to burp? Like, that's a question I like to ask. And that will kind of take me in a very specific direction. And if the gas is mostly flatulence, already that kind of narrows it down. Like, okay, well, are you super farty because you're constipated? Are you super farty because you're maldigesting a FODMAP or sucrose, or, that you have SIBO? And so already just by asking about gas and where the gas is, you can already kind of really start to narrow down and sort of ask differentiating questions around those particular conditions. You also want to know if the bloating or their distension is associated with altered bowel function. Sometimes people will say like, I'm bloated or distended, but my poops are totally normal, like regular, like, like a train schedule, like soft, formed, easy to pass. They feel complete. Nothing's changed. This is my total normal, in which case, you can probably rule out a lot of things. Like most people with SIBO do not have unchanged bowel movements. If it's really like no change in their bowel stuff, you really want to be focusing on some of those upper GI etiologies versus, yes, I'm so bloated and now I'm having diarrhea all the time. Okay, well, what are you maldigesting? Carbohydrate wise, or is it like a SIBO situation, or a celiac disease situation, right? Or, I become a lot more constipated and I'm not going as much. And then obviously like that should take you right into the constipation route. And so, just understanding the altered bowel function, yes or no, kind of takes you to a place of upper GI or lower GI, and already is very differentiating. And then just trying to understand how or whether their bloating or their distension correlates to eating. No correlation at all, that tells you something, right? Like maybe we're looking at a non-GI cause like endometriosis. Maybe we're looking at, like an air swallowing, which might just happen when they're sleeping and, mouth breathing overnight, or, and so if there's really no difference in eating, I don't know how much we as a dietitian necessarily can help, but if it correlates to meal size and volume, often your constipated patients who are full of stool feel much more bloated and distended when they eat larger amounts versus smaller amounts. Obviously, your patients with gastroparesis or functional dyspepsia. If people say like, I'm never bloated after eating sushi, but I'm always bloated after eating salad, that's also something that's super helpful, right? Like big fiber meals are really bloating. Well, maybe there's no room in there for that big bowl of salad. Maybe your bowel's already full of stool, and that's why the lower fiber things are less bloating for you. Or maybe things correlate to FODMAPs, right? Like someone could eat a salad, which is low FODMAP, and feel amazing and not bloated, but then they have like, a soup that has like onion and like chicken soup bloats them. Like that should take you to a place of FODMAPs or SIBO, right? Because that's not a fiber issue. That's probably a FODMAP issue. And so asking these differentiating questions will give you a hypothesis that then you can take with you into a food and symptom recall. So now if I think, oh, based on those few questions, like I think maybe my patient could have gastroparesis, like a slow stomach. Then when I'm taking my 24-hour diet recall, I'm asking how quickly they feel hungry again after eating. If I have, a banana and a yogurt for breakfast at 10 and I'm not hungry again until 4 p.m., does that sound normal to you? Like, does that resonate as something that most of your patients would experience? And then maybe you might say to the doctor, hey, like maybe we should evaluate for gastroparesis. Or if it's like, you think that it's a FODMAP issue, you might ask specific questions about high and low FODMAP foods to kind of test your hypothesis. And so entering into the 24-hour diet recall already with the hypothesis in mind will help you narrow in by the end of your session about where you want to go. Okay, I'm going to breeze through real quick a bunch of medical conditions. You can watch this presentation again at halftime if you want to really dive deep. Gastroparesis is delayed gastric emptying. It has to do with dysfunction of the pacemaker cells, which are the interstitial cells of Cajal. People are often nauseated. Nausea is probably the number one complaint you get with gastroparesis. Sometimes they may even vomit, terrible reflux. They may or may not have weight loss, if, they're just not able to eat as much. They have early satiety, like they eat something and then they're not hungry again for 5 or 6 or 7 hours. It can be painful. It's not just bloating. Gastroparesis can actually be painful. And we generally, dietitian wise, would treat it with like lower particle size fiber, not necessarily low fiber, because obviously a kale salad digests really differently than a green smoothie. But lower particle size fiber, not so fatty, some liquid meals if needed. And they're both medications as well as sort of endoscopic and surgical therapies to treat gastroparesis. There's prokinetic medications. There are no real over-the-counter prokinetics. I know that there's sort of motility supplements that are being sold. They're not evidence-based to promote motility. There can be Botox injections of the pylorus that can help patients with gastroparesis. There's a procedure called the G-POEM, which is done endoscopically, which can help with gastroparesis. So there are remedies for it. Functional dyspepsia presents very, very similarly to gastroparesis. And you'll see on the next slide, some people argue that they're not even different conditions. It's very hard to tell them apart. The one thing that I see a little bit more with patients who carry a diagnosis of functional dyspepsia is they get full really quickly after eating, but their hunger, their appetite rebounds much faster in my clinical experience, which is to say, like, I can only eat a small amount for breakfast or for lunch, like half of what I used to be able to eat or half of what a normal person eats. But then like 2.5 or 3 hours later, I'm starving again because, my stomach wasn't very stretchy. It's not very accommodating. And so I get full so quickly. But then as soon as my stomach empties, like my body's like, hi, you only fed me a half of a meal. I'm hungry again. And I often don't see that as much as my patients who carry the diagnosis of gastroparesis, if they are different conditions, which we'll talk about in a second. Dietarily, you treat functional dyspepsia essentially the same way as you would treat gastroparesis. They might be able to eat a lot more frequently than your patients with gastroparesis. They might respond more so to tricyclic antidepressants, neuromodulators. FD Guard, which is just caraway seed oil and peppermint oil, has done wonders for some of my functional dyspepsia patients. It's over the counter. You take it before meals. The last 2 years I've gone to DDW, Digestive Disease Week, which is a huge GI conference in May every year. I've seen a presentation with different groups of presenters, physicians, arguing that gastroparesis and functional dyspepsia are the same thing. They are not necessarily distinct disorders, that they might just be one disorder that exists on a continuum, on a spectrum. They cite that there's like this very significant overlap in the symptoms, a very significant overlap in the mechanisms. And they've actually, like some of these presenters will cite one particular study, which I think I have in my references here, where they take a group of people who carry diagnosis, like who have these symptoms, like present with these symptoms, and they do a gastric emptying test in the group. And I think it's like, some people have slow gastric emptying, so they get the diagnosis of gastroparesis. The other group has the same symptoms for the most part, but their gastric emptying test is normal. So then they get a diagnosis of functional dyspepsia. They kind of feel the same all year long, like the two groups, nothing distinguishable. And then when you redo the gastric emptying test after a year, 40% of the people in each group end up switching to the other group. So 40% of people who had like a normal gastric emptying test, like in the beginning of the study, a year later, now have a slow one. And 40% of the people who had a slow one a year later had a normal one. So these researchers are kind of like, like, I wonder if, this is just like one disorder where like there's sort of like these waves of, impaired motility, not always, but the symptoms are generally the same. Should we just be treating them all the same? Like, should we even use gastric emptying tests anymore? Maybe everybody should be offered a a prokinetic with these symptoms, whether or not they have a negative gastric emptying test. So this space is changing. I wonder if in the next 5 to 7 years, are we going to get some different guidelines in the medical community about these conditions? And are we going to be changing what we call them, changing how we diagnose them? Are gastric emptying tests going to go away? I don't know. But I thought it would be interesting to share that emerging conversation that's going on in the gastro world. Okay. Moving on, acid indigestion, dyspepsia, gastritis, all the acid-mediated discomforts and bloats. It's usually epigastric, which is up top here, very high up, right? It's not so low down underneath your belly button. It's almost always after eating, postprandial. Often is accompanied by heartburn or chest pain, esophagitis, acid taste in the mouth or burning in the throat, hiccups, burping. Worse when lying down sometimes. In these particular patients, we're kind of doing the usual stuff, which is don't eat too much at once. Like try not to go more than 4 hours without eating. Otherwise, you're going to be so hungry and then overeat, and then you're going to feel terrible. Sometimes when these patients are bothered by like coffee or alcohol, but they don't want to give them up, I suggest they try to buffer their stomach first with don't have coffee on an empty stomach, eat your breakfast first and then have your coffee. Or if you want to drink alcohol, start eating your meal first, get some carbs in the system, raise the pH of the stomach a little bit once there's food in there, and then try the alcohol. So the alcohol is just not exposed to all this empty blank, tissue in the stomach. It might feel better. Staying up right after meals, don't eat within 3 hours of bedtime, the usual. Okay, aerophagia is air swallowing or air eating, technically. It's often very painful when you are full of air. It is partially relieved on burping. Sometimes anything that you can do to induce burping can help them, right? So like drinking seltzer sometimes causes you to burp, and that can actually be helpful for some of these patients, believe it or not. But the presenting major associated symptom of aerophagia is belching, like constant, loud, embarrassing burping is often a sign that somebody's swallowing a ton of air. They may or may not be doing it with eating. Sometimes they do it when they're sleeping. Sometimes they do it during allergy season. They have postnasal drip. And so they're just always swallowing, gulping, all the postnasal drip stuff. Sometimes patients with OCD or anxiety will swallow a lot just in the course of life in the day. Gum chewers, cigarette smokers, people who are at the gym, huffing away and then chugging water and gulping water. Certain types of exercise can cause air swallowing. So there's a lot of reasons why people might swallow air. If you can help a patient think about it and brainstorm where it might be happening, then you might be able to help them. But it's not always something that a dietitian can really help with, unless it's something so obvious, like they just chew gum all day long, which, I've seen that. You can try telling them, the basics, when you're eating, don't talk while you're eating, because we swallow more air, eat slowly, don't talk while you're eating. Be mindful of gulping and slurping things, like drinking slowly. Drinking from a straw actually helps reduce swallowing air, not the opposite. If you swallow a lot of air when you eat, you can also just try tucking your chin like that before you swallow food, and it kind of pushes some of the air pocket to the front of the mouth rather than the back of the throat. If they're a very anxious person or an OCD, if it's kind of like an OCD behavior, sometimes cognitive behavioral therapy can help, or diaphragmatic breathing can help. And these patients often feel really good when you pump them up full of simethicone, which is Gas X or other brands. Okay, this is a fun new one that kind of came onto my radar screen a couple years ago. And now that I know about it, I've probably caught about a half a dozen cases of it. It's called RCPD, retrograde cricopharyngeal dysfunction, which is basically an upper esophageal sphincter dysfunction, the upper esophageal sphincter, that prevents somebody from burping. And I don't think you realize how adaptive burping is until you can't do it. If every time you swallow air, which is, after this hour talk, at the speed that I'm talking, I'm swallowing a ton of air, I'm sure I'll have some burps this afternoon. Thank goodness. What a relief that will be for me. If I couldn't, then all the air that I have swallowed is just getting stuck in the system, unable to burp. And if it doesn't come out through burping, then it gets stuck in the system and has to go through all the way out until you fart it out. These patients who cannot burp are often so, they feel like balloons. They feel so full of air. They're so uncomfortable. like sometimes they're short of breath because when there's a lot of air in the stomach, it even puts pressure on the pleural cavity, the lungs, and they can't like get a full like lung full of air sometimes. And if you ask them, you know, like, do you have a lot of gas? Like, do you burp or you fart? Do you burp? Do you fart? And they'll say to you, oh, I never burp. And then you'll say, what do you mean you never burp? Like, you never burp? Like, have you ever burped? Can you burp? And if they say no, then, well, the good news is, I can help you. The good news is I know what's wrong with you. The bad news is you just spent all this money to see me and I can't help you. You need to find somebody in your network who can treat RCPD. It is treated with a Botox injection to the upper esophageal sphincter. In New York, I know one ENT doctor who does it. So all these patients get sent to him. He Botoxes them and they're fixed. The best you can do is, you know, give them a ton of simethicone or Gas-X just to break up those big gas bubbles. But there's no dietary solution for this. But unlike other GI conditions, it is completely curable, like with a silver bullet. So that's actually kind of great if you're the one who can catch it. Often these patients have been suffering for like years and decades and nobody's picked up on it. We talked earlier already about abdominophrenic dyssynergia. I'm not going to talk about this again. It's that abdominal visceral somatic reflex that your abdominal wall just completely gives out when the diaphragm pushes down. You look super pregnant. These patients usually come in with a selfie and they show you their before and after. Appetite's fine. They're not in pain. You often see it in patients who have a history of disordered eating. Like patients with a history of binge eating will often have this, but also anxiety, trauma, and those, you know, that background often seems to lend itself for some reason to this type of neuromuscular dysfunction. Carbohydrate intolerances, obviously we're all here as guests of FODzyme. And so, you know, we probably are on mailing lists about carbohydrate intolerances. We know all about them. They can be to any FODMAP, right? Lactose or fructose or fructans or galacto-oligosaccharides. You can also, you know, sucrose is a non-FODMAP carbohydrate malabsorption. And, you know, sucrose intolerance is diagnosed really endoscopically by biopsying the brush border and measuring levels of the enzymes, sucrase isomaltase. And if that comes back low, abnormally low, then insurance will often cover a very expensive prescription enzyme called Sucrade, which patients can just take with every meal and eat whatever they want. These types of, the type of bloating associated with carbohydrate intolerances is usually kind of just like the whole mid-abdomen. It might be uncomfortable. It might be overtly painful if they have a lot of gas. They will often be very farty. The farts smell really bad. They often have diarrhea. Diarrhea is not immediately after eating. It's usually earliest 2 hours, usually closer 4 to 8 hours after consuming a trigger food. And so, for example, if a patient says like every day at like 5 o'clock or like, you know, every day at 3 o'clock, I get super gassy, farty, bloated, uncomfortable. You want to kind of count back like, you know, 4, 6, 8 hours before that. What are they eating habitually is kind of the way that I like to do that. It often works really well. Sometimes their stools will be light colored, orangey, tan. They might feel like they're burning or very acidic on the way out. And with these particular patients, some strategy of either avoiding the trigger food if there is not an enzyme available to supplement. So for example, if you discover that polyols like really trigger your patient, then they're just going to have to avoid polyols because there is not yet an enzyme for polyols. But for pretty much all of the other carbohydrate intolerances, we now have either individual enzymes or enzyme cocktails or prescription enzymes. And so, you know, you can really use enzymes, lactase, obviously for lactose, alpha-galactosidase is Beano or Beanzyme. It's also an ingredient in the FODzyme cocktail. So if your patient has multiple intolerances, then instead of taking like 10 different things, they can take one thing. Xylose isomerase is the enzyme that helps convert fructose into glucose, and that's available online. So there's options for these patients. I rarely do much by way of elimination diets for these conditions anymore because enzymes are so available. SIBO is a big one. Obviously, SIBO dietarily will often present in secondary intolerances to high FODMAP foods, right? I say secondary because these are not organic, native to the person intolerances. These are intolerances caused by SIBO, which is treatable, theoretically. These patients feel fine in the morning. depending on what they eat, will start to experience very rapid onset gas and bloating, usually after a high FODMAP food, but not always FODMAP. Sometimes these patients will feel very sensitive to just sugar, and sugar is not a FODMAP, or sometimes they'll feel very sensitive to simple carbs, things like rice or bananas, which are technically low FODMAP, but a lot of, like, sometimes you'll see a SIBO patient who just feels that I can eat low carb and feel great, even if the low carb diet includes like cauliflower and other FODMAPs, but for them, it's like rice and sugar really bother them. So not everyone with SIBO presents with a FODMAP intolerance, but I would say it's more common. Sometimes fat can also really trigger these patients. Sometimes these patients will just say it's just fruit. All fruits bother me, but then other foods not so much. So there's a lot of presentations of SIBO from a diet perspective that you should just be aware of. Usually there's a change in bowel patterns. It's very unusual for a SIBO patient to have completely normal, unchanged stools. Not unheard of, but not typical. A big red flag for SIBO is an unexplained vitamin B12 deficiency, right? SIBO utilizes vitamin B12, or bacteria utilize vitamin B12 for their own metabolic purposes. So people who have too many bacteria in the small bowel will often find that they become deficient in B12, even if they are not vegetarian or vegan. So like, diet has plenty of B12, why should this person be deficient, is a huge red flag, and you should be looking for SIBO for an unexplained B12 deficiency. In these particular cases, a well-chosen antibiotic is the only evidence-based treatment for SIBO. I say well-chosen because not all antibiotics are up to the task for different types of SIBO. And someone who did not respond to Xifaxan and who keeps getting Xifaxan over and over again is probably not going to get better the second, third, or fourth time they're offered a treatment that didn't even work the first time. There are multiple antibiotics that can be used to treat SIBO. The American College of Gastroenterology, the ACG, has a guideline paper that's just a couple years old that has a table 5. It lists all the different antibiotics that can be used at what doses. And so if patients are hitting a wall with their doctor, you might suggest that the patient share that paper with their doctor to talk about whether a different antibiotic might be more effective than the one that they keep getting over and over again. I generally try to avoid probiotics, not generally, I always avoid probiotics in my SIBO patients. Constipation, the number 1, 2, 3, and 4 reason that your patient is probably bloated and constipated. Even people who poop every single day can be full of stool. It's not enough to just say, do you go to the bathroom every day? Are you constipated? You want to look at their diet and figure out how much fiber is this patient eating? And is the one nice normal poop they get a day anywhere near sufficient to keep up with the amount of fiber that they're eating? That is the absolute most common. If someone says that they're constipated, they skip days, they have pellety stools, that's easy. But what's not obvious that every other doctor has missed and what the patient has missed that you're going to pick up on is they say, I get one good bowel movement a day that looks like this. And then you take a diet history and you see that they're eating fiber with fiber with fiber with fiber. They're having overnight oats with chia and flax and walnuts and berries. And then they have a giant kale salad with 50 different vegetables in it. And then their snacks are celery and carrots and popcorn and nuts. And then dinner is low carb because they're weight conscious and they're having 75% of their plate is vegetables. And then they have a small piece of fish. And they tell you that they poop once a day like this. No way. Most people who eat that much fiber need to be pooping 3 to 4 times a day like this. And so sometimes if you can pick up on a disconnect between the fiber going in and the fiber coming out, you will be able to tell a patient, I think you're bloated and constipated because despite the fact that you poop every day, you're actually full of stool. And this can be objectively verified with imaging, KUB x-rays or CT scans. Not that doctors will ever order a CT scan to look for poop, but sometimes patients who have been complaining of bloating have already gotten a CT scan looking for cancer. And then you can say, hey, why don't you ask your doctor to look back at those images from your CT scan that you've already had done and ask them to comment on your stool burden. And then they'll call back and say, oh, my doctor said it was very high, but they just didn't mention that. So, these patients they always wake up a little bit distended, but that's still their best time of day. With each passing meal, the belly distends. They go to bed very uncomfortable, pants don't fit, farting up a storm. Having a bowel movement alleviates it a little, but not completely, because it's just not enough, right? The bowel is 5 feet long. And if it's 5 feet full of stool, having one bowel movement isn't going to be enough. And so that's kind of what this type of constipation looks like. These patients feel worse after salads and high fiber, better when they eat unhealthy, right? Because a sandwich has no fiber and, a burger has no fiber, and often that feels better. And they're so frustrated because they're like, I'm doing everything I'm supposed to. I'm eating high fiber, blah, blah, blah. And I'm eating so healthy and I'm still so uncomfortable. So that's these patients. What you're working on with this patient dietarily is less in and more out. These patients need to be in a bowel regimen, magnesium, senna, whatever you want to use, Miralax, and temporarily a real big pullback on the amount of intact, coarse, high residue fiber, so that every gram of stool they manage to poop out is not being replaced by 3 grams of salad, or you're never going to get ahead of the problem. If they're unresponsive to a bowel regimen, if like you go high dose magnesium or high, they take Senna every night or Miralax, whatever, and like really nothing is getting better, you really might want to think about having their pelvic floor function evaluated, because maybe they can't go and they need a different type of intervention. I kind of talked about this already. I forgot I had this slide, but I said all these things. You can have a high stool burden even if you have normal bowel movements. You're looking for that mismatch between in and out. Sometimes these patients will say, I'm kind of prone to diarrhea. Like I used to be really constipated and all of a sudden it turned into diarrhea and I have no idea why. Well, that diarrhea is something that we call overflow diarrhea, which is now you are so backed up that there is no room for more solid stuff in the GI tract, and all the fresh young stool entering into the colon is literally like kind of slipping around the sides of this obstipated stool burden and just coming out as diarrhea. Or sometimes the dam will just break. They get so built up, and the pressure just causes like a day where they have like a washout and they just go back and forth to the bathroom 5, 6, 7 times and have formed stool. So it's not technically diarrhea, but they're like, I feel like I've just emptied my entire bowels and then I don't go for 3 days. Sometimes if you suspect a stool burden, like even if they're regular, but you see that they eat a lot of fiber, why don't you ask them, like, are your stools like really enormous? And then they'll be like, they'll turn red, they'll blush, they're like, oh my God, like, yes, like, I can't believe you knew that. Why are you asking me that? Because sometimes the patients who are really, really full of stool will poop out like stools that are like a foot or more long, and they fill the entire toilet with the poop. And they're like, I cannot even believe that that was inside me. And then they have 2 or 3 of those a day. Well, guess what? If you can fill the toilet 2 to 3 times a day, then all of that stool was sitting inside your colon. Like you were very full. And so these are kind of the questions that you can get into and really try to evaluate whether your patient has a very high stool burden. These patients will come to you, they say, I've tried everything. I've gone gluten-free, I've gone dairy-free, I've done low FODMAP, like nothing helped. Diet doesn't make a difference. They're very gassy. And like I said, these patients often can have a pelvic floor dysfunction, but not always. Sometimes they just have slow motility, and sometimes they have normal motility and just they eat too much fiber. Okay, IBS, we talked about it earlier. It's a disorder of the gut-brain interaction where you have visceral hypersensitivity. The hallmark characteristic of IBS is pain. Okay, not everyone who has diarrhea has IBS. Not everyone who has constipation has IBS. If there's no pain, it's not IBS. And so with IBS, you're trying to manage the constipation or the diarrhea, or the gas burden, the normal ways that you would, right? Maybe with FODMAPs, maybe with, fiber supplements, maybe with laxatives, like however you would. But that extra element of pain sometimes needs additional intervention. As dietitians, peppermint oil, and terracotta peppermint oil can be really helpful. Also some of those behavioral therapies, gut-directed hypnotherapy, cognitive behavioral therapy can kind of help with that pain threshold. But, kind of making sure that they're not full of gas, not full of stool will often just alleviate the pain as well. Doctors can prescribe antispasmodics for the pain, right? These are some of the options available for an IBS patient. And so, we kind of talked about all these as we went throughout, but I'll just kind of summarize. The types of medical nutrition therapy that are generally the ones you're going to be thinking about when you deal with a patient who has bloating or distension or both is what I call the GI gentle diet, which is kind of thinking about how much space the fiber they eat takes up. Big, coarse, bulky, roughagey, insoluble fiber, salads, things with thick skins, nuts, popcorn, peels, like those types of intact, bulky, coarse fiber generally don't feel as good because they take up more space and they're really bulky. So limiting that type of intact fiber and kind of getting more soluble fiber as the basis of their fiber, using texture modification, so smoothies and soups to kind of get some of those things like berries and spinach, so they're not eating all that stuff intact and raw, can be really helpful so that you have minimal restrictions to their diet. If we think that there are carbohydrate intolerances driving a gas burden or driving some diarrhea, you're thinking about either eliminating or using enzyme supplements. You know, again, my bias these days is more towards the latter, and especially in a patient who has a history of disordered eating or ARFID, you don't want to be putting them on an elimination diet. Teenagers, children, like you really want to be minimizing elimination diets in vulnerable populations. Meal sizing, meal spacing can help with bloating. Obviously, if you already feel overfull, doing intermittent fasting and then eating all of your calories in 2 meals a day is not going to feel as good as spreading out your daily volume intake into smaller amounts, you know, evenly spread over a longer time period. And evidence-based supplements to help. We talked about some of them as we went: bowel regimens, peppermint oil, enzymes, things like that. For SIBO, we don't actually have any data that I'm aware of that kind of that talks about what diets are most helpful and that compares different diets. You know, the ones that are generally in circulation are low FODMAP. It's probably the most common. It's the least restrictive, but still not easy. Specific carbohydrate diet is sometimes used. Sometimes it's used along with low FODMAP, which is just like basically like a lower carb, low FODMAP diet, which I personally find to be excessively restrictive. You know, we're hearing a lot about the elemental diet. I've never used it to treat SIBO or to manage SIBO symptoms. It is, I don't care how palatable these companies say their elemental diets are. If you've tasted them, they're not palatable. I'm sorry. Sorry, not sorry. It's incredibly restrictive. You have to be on these diets for anywhere from 2 to 4 weeks of nothing but very yucky tasting formula drinks. Very expensive. And we don't have really any great data that show that it eradicates SIBO for any amount of time. Like, if it does get rid of SIBO, for how long? Like a week or for like months or years? And so it's a really expensive, tough diet to recommend when we don't have a lot of confidence that it's going to eradicate SIBO for very long. Diet doesn't cure SIBO. No diet has been shown to prevent SIBO. The role of diet with SIBO is symptom management. Do not over-restrict, do not over-promise. Diet is a very limited role in SIBO. It's so that you're not miserable and suffering until the SIBO is treated. Here's just a summary of evidence-based remedies. Oh my God, we have so many questions in the chat. I'm going to talk faster. I'm sorry. For constipation, we start at 400 milligrams of magnesium oxide or hydroxide and go up to 1,200, frankly, even 1,500, as long as there's no kidney issues. I love Senna. Senna is great for your extremely, extremely backed up patients. It's not habit forming. It's not dependency forming. It's safe to take at, you know, physiologic doses, which is usually 1 to 2 Senna a night. You can go higher. Psyllium or Fibercon, which is calcium polycarbophil. I kind of love it for people who don't get enough fiber, but if they're already full of stool and full of fiber, you would not want to supplement more fiber. For pain, we love peppermint oil, lots of different brands. For functional dyspepsia pain, we love FD Guard, Iberogast, although it's very hard to find and it's kind of expensive and it doesn't taste so good. Ginger can be helpful for functional dyspepsia. You cannot get enough simethicone in a lot of these patients. It's cheap, it's safe. You can use it 5, 6, 7 times a day, despite what the label says. Curist is a new brand out there that sells simethicone that doesn't have any polyols in it. So a lot of the brands of Gas-X and Phazyme have sorbitol or, you know, mannitol or things that are FODMAPy, and Curist doesn't. So it's kind of a nice new brand to have on your radar screen. We talked about all the enzymes you can use for carbohydrate intolerances. For people who have acid indigestion or reflux, there's a newer product that I really, really love. It's called Reflux Gourmet. It's basically alginate, sodium alginate, which is algae-derived goo. And when you take it after eating, it kind of coats the esophagus and creates this like floaty little barrier right atop the stomach, and it kind of seals off that lower esophageal sphincter and prevents acid from refluxing. So it's great for people who get dyspeptic after meals or bloated after meals or when they're lying in bed, to take it after meals or take it before bed. It's a medical food. It's safe. it actually tastes good. People really like it. Okay, so practice applications. Take the time, explore what your patient means when they say that they're bloated. What are they really saying to you? What are they really experiencing? Ask differentiating questions so you can develop a hypothesis in your brain of one or two, either foods or medical conditions that you think it could be. And then ask specific questions as you're doing the recall to test that hypothesis that you have. Are you right, or are you barking up the right tree, or are you not barking up the right tree? And then whether or not your patient has a diagnosis, it doesn't mean that you can't do your job. Even if they don't have a diagnosis, you can make an educated guess what you think it could be, and then put them on the diet for that thing. And if they get better within 2 weeks, you've just created diagnostically relevant data that they can share with their doctor and say, like, well, I'm not really sure. I know that we don't know what's wrong with me yet. I know I don't have a diagnosis, but I met with a dietitian and she thought it could be X, Y, and Z. And she put me on this diet and I'm miraculously better and I'm amazing. And that might help the doctor be like, oh, then let me test you for X, Y, or Z. And so, you don't have to have a diagnosis to help a patient. Remember, not all bloating is diet related. Not all bloating will respond or improve with a diet intervention. Sometimes knowing when you can't help is also important. What else? Be careful of alarm symptoms. Some things are very serious. We are dietitians, we are not doctors, and we also have to know when we should be referring for medical attention when bloating is accompanied by an alarm symptom. So I think I'm done. Jocelyn, I'll hand it over to you.
Wow, thank you. Okay, that was fantastic. We obviously have a ton of questions. We'll get to a couple of these, as many as we can for the next few minutes. Here's our first question asking how the abnormal viscerosomatic response may be diagnosed. Possible.
Great question. So in our practice, the way that the physician diagnoses it is he does it through a physician. We have more than one physician. He does it in a test called anal rectal manometry. All right, it's an in-office test that some gastroenterologists or motility specialists do. They send a catheter up the butt that has like a deflated balloon at the end. The catheter is attached to like air, and then the air goes to the catheter. It distends the balloon, and the patient has to poop the balloon out. That's one of the ways that we diagnose pelvic floor dysfunction. But in our practice, the way the physician will also test for abdominal dyssynergia is before he starts the test, he'll actually take a measurement of the patient's waistline and see what like the baseline fasted flat belly waist circumference is. And then after he infuses the balloon, I think it's with like 200 cc's of air, he retakes the measurement. Because the normal abdominal wall should not distend more than about 2 centimeters with that much volume of air in the abdominal cavity. And if he sees this huge delta between the baseline and I just put 200 cc's of air in the entire abdominal cavity and like the belly is like whoosh, and he takes that measurement, and that's how he has been diagnosing it. Before he started doing that in our practice, he would just do it very subjectively. He would have patients take a shot. He had a shot glass and he had some Ensures and he would like have patients, they have 1 ounce shot of Ensure and measure the belly and have a second shot. And he would kind of see like, could they finish a whole Ensure, which I think is like 8 or 12 ounces without, this again, like more than like a centimeter or 2 distension. Like in other words, does even liquid make your belly completely stick out, right? Because you can imagine if you drank a glass of water first thing in the morning, is your belly like, I mean, I don't know you on the call, like maybe you all have abdominal dyssynergia, but like for me, like if I had like a glass of 8 ounce water, in the first 15 minutes of waking, my belly would not be measurably distended, but some people's are. So like, I don't know that there's these objective consensus-based diagnostic criteria for it. I think it is somewhat still of a clinical diagnosis rather than an objective one. But I think that that's changing. I mean, there's so much more literature now on abdominal dyssynergia. I think it's a matter of time until clinicians get much more objective diagnostic criteria that they can apply more uniformly.
Thank you. Here we have a very meaty one from Allison asking about bloating versus distension during a woman's menstrual cycle. Could you touch on this a bit? Is it hormone related?
Yes. If it happens in the menstrual cycle, it's hormone related.
Okay, thank you. How about here, can stress cause bloating or distension related to the vagus nerve?
Probably, I mean, it's not that stress causes it, right? But if you are under stress, you might be more responsive to diaphragmatic breathing to reduce the stress response in terms of reducing, I would say, probably feelings of subjective bloating and distension, right? And so, not distension, but subjective bloating. I don't know if it would actually impact visible distension. So if someone feels very bloated and uncomfortable when they are stressed out, they might be a very good candidate for diaphragmatic breathing.
Thank you. Here we have a clarifying question from Beth related to straws. Does that reduce swallowing air or increase it? Just wanted to confirm.
It reduces it. Think about it. When you have a straw fully submerged in liquid, there is no air in the liquid. So the only thing that a straw would like increase air swallowing is if there's like very little liquid left and you're trying to get the dregs, you're like there's like nothing left, you're just trying to get like, you know, the little bit of extra liquid in an empty cup. Yeah, then you're going to swallow a lot of air. But when a straw is fully submerged in liquid, your mouth is closed and sealed around a straw. So you're not open mouth on a cup taking in air. Your mouth is fully sealed and the straw is fully submerged in an airless matrix. So yes, straws are good for aerophagia unless you abuse them.
Thank you. Here we have a question. Are there any contraindications for taking magnesium or senna long-term?
Contraindication for magnesium would just be if you have kidney disease. Yeah. Or like some weird like hypermagnesemia, whatever. But like, no, I mean, they're very, very safe at physiologic doses for long-term use.
Thank you. And this will be our last question. Do you recommend probiotics once someone recovers from SIBO? If so, what kind?
No.
Okay.
No, and I'll tell you why,
Yeah,
because
please.
we don't know why you got SIBO. And if you have a bowel that is prone to overgrowing bacteria, and we don't know why, or we do know why, but we haven't treated it, why would I want you taking bacteria pills in a bowel that we just managed to clear of excess bacteria that we know is vulnerable, that have some sort of guardrails that are failing to protect it from overgrowing bacteria? Why am I giving you bacteria pills?
Thank you.